Sir, should we start now? We are
Yeah,
in
I'm
live.
waiting. We are over time. We are overdue.
Yeah. Hello and welcome to all. This is Ankana, the assigned moderator from IJCP Group. I wholeheartedly welcome all the delegates across the country. We are fortunate enough to get supported by the doctors. Thank you all the doctors for taking out time to join us today. Now I am taking this opportunity to welcome today's master doctor, none other than the eminent speaker, Dr. Kuresh Maskati, sir. Sir is MBBS, MS, DOMS, FCPS, FICS. He is the consultant ophthalmologist at Maskati Eye Clinic, Mumbai. Now, with the help of Dr. Maskati sir and his wonderful insight, we will be taking a close look on today's topic, which is eye watering and discharge from birth to old age. Without any further delay, sir, I would like to hand over the session to you. Kindly proceed with your topic. Over to you.
Thank you, Ankana. And I will just share my screen. So today's topic is an interesting one. Patients who are suffering from I'll just with patients who are suffering from watering and discharge from birth to old age, and we'll see how it goes. Now, the earliest patient who suffers from discharge from the eye is a newborn. So a newborn has coming out with redness of the eye with discharge, lot of copious discharge. It is known as conjunctivitis of the newborn or ophthalmia neonatorum. In ophthalmology, we give very large names to diseases because it makes us feel very important. So the eye is a three-letter word, not very significant. So we call it ophthalmology. So it sounds very good. Similarly, conjunctivitis of the newborn seems very plain and ordinary, but ophthalmia neonatorum sounds like a dreaded disease. It's the same thing. Usually it's due to infection from the mother's birth passages. If the patient has had a natural delivery and not a cesarean section, then sometimes from the cervix or from the vagina, there is some infection and that gets transmitted to the child. Or the carelessness of the caregivers, the people who are handling the birth, the technicians, the nurses, or whatever may transmit some infection, but usually it is from the birth passages. So if it is pseudomonas, which is quite common, then there may be a thick purulent discharge, sometimes foul smelling and green. As you can see in the pictures, the eyes get clotted up, closed, and the eyes don't open because of such discharge. Earlier, it was treated before the antibiotic era. This was well known, and it was treated with an antiseptic called silver nitrate, which is a broad spectrum antiseptic that is called Creedy's method. But now it is treated via modern antibiotic eye drops. So we get the nurses are trained to clean the eyes carefully, remove the discharge, and put antibiotic eye drops. And it usually subsides in about 3-4 days. The cornea is not usually involved. So earliest discharge is at birth itself. Then as the child grows a little older, parents typically say that, sir, for the first 4 to 6 weeks, there was no problem. But now one eye, there is some watering coming from the eye. Why do they say this? Because newborns actually have no tears when they cry till the age of 4 to 6 weeks. So if there is a blockage in NLD is nasolacrimal duct or the nasolacrimal passages, if there is a blockage in the nasolacrimal passages, then it manifests only after the child is 6 weeks old. So you get watering from that eye. It may be one eye or it may be both eyes. Unless there is secondary infection, there will not be discharge. The parents will only say that it is watering, the eyes are not stuck or anything, but there is a constant water coming out from one or both eyes. So what is the treatment of congenital nasolacrimal duct obstruction? It is called congenital CNLD, nasolacrimal duct O obstruction, CNLDO. So the procedure is called Kriegler's massage. We train the parent to massage. We tell them, please cut your fingernails so that you don't damage or abrade the skin, and press hard over the bone between the eye and the nose. You press hard, as you can see in the picture there, and push with a downward movement and with a backward movement, that means pushing to the back of the head and down towards the nose or the mouth. So push in that direction between the eye and the nose and massage like this at least about for 4 or 5 minutes, 2 to 3 times a day. This is called Kriegler's massage.
Hello,
And
sir.
what happens is that
Sir,
usually,
sorry
yes,
to interrupt, sir. Your slides are not moving,
oh, okay,
and it's not full screened as well.
I'll see. We'll just, uh,
Yeah.
is it full screen?
Yes, sir. Yes, sir.
Shall I go back?
Yes, sir. From the yeah.
Okay, so this was the first slide where I talked about ophthalmia neonatorum or conjunctivitis of the newborn. And this is the pictures that I said of the eyes clotted up close together because of such discharge. It needs to be cleaned with just wet cotton, and then you can put the antibiotic drops, and they usually do well. Congenital nasolacrimal duct obstruction. As I said, newborns have no tears earlier, so it manifests at about 6 weeks or later. One or both eyes may be watering. If there is any secondary infection, then you will get discharge. This is what you can see the picture there of the child with the watering from one eye. And this is a picture of the nasolacrimal. So the eyes have two tiny openings called puncti from which the tears flow out into lacrimal canals or lacrimal canaliculi, just to make it a longer word. Upper canaliculus and lower canaliculus, they both meet and form what is called a common canaliculus that you can see, and then they flow. Can you see my arrow, Ankana? Is my pointer arrow visible to you, Ankana?
Yes,
Okay.
sir. It's visible. Yeah.
Okay, so this is the common canaliculus, and then the tears flow into the lacrimal sac. The lacrimal sac is between the eye and the nose, and then it empties, it goes through a nasolacrimal duct and goes and opens into the nose under one turbinate, under the inferior turbinate. So this is the normal passage. Many times there is a blockage. Usually the blockage is somewhere either in one of the canaliculi, or it could be in lower down as well. The treatment for this is very simple. We do this, as I said, this Kriegler's massage, where we massage the eye with the finger point pushing from up to downwards and little posteriorly or behind. And usually this little mucus plugs or epithelial debris are blocking the passage, and they clear out, and the watering disappears. You have to continue this for about 2 to 3 months before you say that it is not working. We call the patients, the mother and the child, and again confirm that they're doing it correctly. Many times, though we teach them this, they're not doing it correctly, and then it doesn't work. They don't need antibiotic drops unless there is discharge. Simple massage about 4 or 5 minutes a day, 3 to 4 times. And we tell the parents that if the child doesn't cry, means you're not pushing very hard. So don't be gentle. If this doesn't work, and if the parents say that they have done the massage well for about 3 months and there is no change in the watering, then we may take the child up under general anesthesia and do what is called NLD probing or nasolacrimal duct probing under general anesthesia. We pass a silver probe through the canaliculi and upper canaliculus and lower. Upper is easier because it goes straight down, and we push it till it comes out and into the nose, and we put another probe through the nose to just verify. So if the two probes touch each other, that means we have created a passage. It is important that it's done by an experienced surgeon, otherwise false passages may occur. This is almost 100% successful if we do the probing before the child is 1 year old. The more we delay it, the more rigid the passages become, and the more difficult it is to get success. So if it is done when the child is 2 years old, the chances of success are only about 80%. If it's done at 3 years old, it's about 60%. The good thing about probing is that if you have not created false passages, you can always repeat the probing under GA after a couple of months. What about adults? Epiphora is the technical word given to watering. If there is blocked nasolacrimal duct in adults, which can happen due to infection, trauma, inflammation. Um, then how do we first diagnose it? Because there are so many causes of watering, which I will show you later. So we do a simple syringing. We just take a syringe with a blunt cannula, not a sharp needle, and push saline through the lower canaliculus. If the saline comes out from the same canaliculus, that means the lower canaliculus is blocked. We repeat this through the upper canaliculus, and if again comes out, regurgitates from the same canaliculus, we call it a canalicular block. It is treated by a different method. And if the regurgitation goes through the upper, so if I'm pushing the water through the lower canaliculus and it comes out from the upper, then there is a blockage, as you can see. Stenosis, this black portion of the nasolacrimal duct over here. So then we make a new passage from the lacrimal sac into the nose, opening it under the middle turbinate. So there are three turbinates, superior, middle, and inferior. So we make an opening, we open the bones of the nose as well, so as to make a new passage. So this diagnosis is by syringing of the nasolacrimal passages, and we come to a conclusion as to what we should be doing in these patients. So this is just again a close-up view of the punctum, through which the canaliculus goes into the lacrimal sac and down into the nasolacrimal duct. This, as you can see. So what is the treatment? If it's of recent origin, it could be due to infection. You can try antibiotic drops. But if it is chronic, dacryocystitis is nothing except inflammation or infection of the lacrimal sac. So this is the lacrimal sac. If that gets inflamed and this passage is blocked, it may be, patient may say that it's been watering and discharged from the eye since 2 to 3 years also. So then it will not improve with medicine. Surgery is required. If it's an elderly patient who's fed up of the discharge coming, and then what we do is we simply remove this lacrimal sac. It's called dacryocystectomy. So this lacrimal sac itself is removed. Now the water will still come out from the eye because there is no way in which can go into the nose. So it will come out from the eye, but usually in 1 to 2 years, the body adjusts, the tearing gets reduced, and in about a couple of years' time, the watering may stop. However, more scientific, more physiological method is a procedure called DCR, or dacryocystorhinostomy. Dacryos means anything to do with lacrimal. Cysto means this lacrimal sac. So a new passage is made from the lacrimal sac into the nose. So rhinostomy, because rhinos is nose. So we make a stomy or an opening into the nose. We can put a tube there, either temporarily or permanently, so that it remains open. Or if we make a sufficiently broad opening, the chances of success are greater than 95%. So this is how we treat epiphora in adults. Then let's go on to some other conditions which can cause watering. So subconjunctival hemorrhage can occur either by a blow, an injury, or on its own you can get the small blood vessel breaking and giving rise to this horrendous looking things. And because there is chemosis or edema of the conjunctiva, you can get some amount of watering. For a few days, it needs no treatment, no antibiotics. It disappears in about 10 to 15 days. Sorry. In allergy, you get a stringy or a ropey discharge. So there's not watering alone, but you get a stringy or ropey discharge. If the patient puts his fingers in, just like people like to dig their nose and pull out strings of mucus, here also you can pull out strings of mucus by in an allergic eye. So this is a typical allergy which is around the limbus. This is called bulbar. Bulbar means in what you can see of the eye. So this is bulbar allergic conjunctivitis. And if you get it under the lid, this is called palpebral allergic conjunctivitis. So you can get either bulbar like in these pictures, or you can get a palpebral type of allergic conjunctivitis. All of them will give you stringy or ropey discharge. Allergic conjunctivitis has got many classifications: atopic, vernal, spring catarrh, perennial conjunctivitis, seasonal. In our country, it is usually a perennial, that means almost all the year round. Abroad, it is more due to allergy due to pollen. So it comes more in spring season. That's why it's called spring catarrh. As I said, it could be palpebral or bulbar. If the cornea is involved, because these palpebral, the palpebral variety, the papillae, rub against the cornea, causing an abrasion and an ulcer. It's called a shield ulcer because it looks like a shield. So this is the palpable variety, this is the bulbar variety, and this is the shield ulcer that you can see. So diagnosis is a no-brainer. Stringy discharge, watering, and itching. Itching is the most important thing. Without itching, you don't diagnose it as allergic conjunctivitis. On eversion of the lid, you'll see papillae, or you can see them around the limbus, or as I told you, you can have a shield ulcer. And treatment is, if you know the allergen, like abroad, it is more due to pollen. So we tell the children to stay indoors during the pollen season. But in our country, that is not practical. So we do give cold compresses, sunglasses, and ask them to improve the hygiene because otherwise the allergy continues. And then there are medicines that we can give for this. We won't go into the details. They are basically mast cell stabilizers because these mast cells release inflammatory material, and that perpetuates the allergy. So antihistaminic drops, mast cell stabilizers are there. And we also have dual action drugs which can do both. So they are both mast cell stabilizers and H1 blockers. So they stabilize the mast cells and decrease the reaction to the allergen, and they prevent the itching as well. Freely available ketotifen and ketorolac, and some of the other drugs which are mast cell the dual action, olopatadine, pipotastine, alcaftidine, just to mention. Steroids are used only in very severe cases because steroids can cause dryness of the eye. It can cause cataract and can cause glaucoma and blindness. So we use it only for very severe cases, only as a pulse therapy for 3 to 4 days, and then stop it, and the other drugs will then take over. Funnily enough, watering can occur in a patient with dry eye. We see a lot of patients with dry eye nowadays because of our computer use, digital eye strain, what we call, we blink less. These are some of the filaments that can be seen, and you can get mucus at the canthus. Just a little bit of mucus can occur at the canthus, and these are some of the other pictures of dry eye. But almost 15% of dry eye patients will present with watering. Some of the common causes of the dry eye are what I call A, B, C, D, E. A stands for aging. Tears are 60% less at age 60 as compared to age 18. So the tears themselves are produced less. We blink less as computer programmers or those who are on the screen or addicted to social media on their mobile. The blink should be about 20-25 times a minute. But if you're addicted to the screen, your blink becomes about 7 to 10 times a minute. So when you blink less, the tears don't spread evenly across the eye, and that can produce a dryness of the eye. Contact lenses give an increased surface area from which tears get absorbed. Many drugs like antihistaminics, antihypertensives, anti-diabetic medicine, antidepressants, all of them can cause dryness. So we need to take a proper history. And environment, if you're in a hot, dusty environment or working in a chemical plant, or if you're even in an air-conditioned environment all the time, air conditioners suck out the water from the room and throw it on the neighbor's balcony with a tube, with a pipe. And then the room doesn't like to be without water, so it sucks out water from your eye. So most of the time, don't get fooled by watering. It could still be a patient of dry eye, especially if he's on the computer for 14 hours a day or is an elderly patient. So suspect this and treat with simple tear drops. I won't go into the details of the management of dry eye, but mainstay is tear drops. Let's move on to another condition, which is called infection, or the commonest one is conjunctivitis. Usually conjunctivitis is viral. The picture that I've shown you over here, the faded picture, is from my father's collection. He was an eye surgeon. This is about 60 years old. Just to show that nothing has changed in conjunctivitis. Again, it is usually viral. The redness is away from the limbus. It is not, this is the limbus, is the junction between the black and the white. So there's no redness here. The redness is more in the periphery. And you can get watering from the eye if it is viral. If there is secondary bacterial infection, like in this patient, then you might get some discharge as well. The gentleman that you can see below, both eyes are red, and there's only watery discharge, so it is more likely to be a viral infection. You can treat these with simple antibiotic drops to prevent secondary infection. Don't give very high uh, fourth generation fluoroquinolones. It's not required unless there is a bacterial conjunctivitis. Uh, Not only conjunctivitis, but if other parts of the eye, like the cornea, are involved, you get a corneal ulcer or a corneal abscess, as you can see over here, the white on the cornea, or infective keratitis. It could be bacterial, fungal. You need to refer these to the eye surgeon. This will cause a lot of discharge from the eye, but it needs scraping to see what the organism is and then treat accordingly. You can get infective scleritis. The white portion of the eye gets inflamed. You can get non-infective keratitis. That means the cornea is, you'll get watering from the eye from without any infection being there. It is non-infective, like a corneal abrasion, that can also give rise to this. And uveitis or the iridocyclitis can also give rise to watering, but no discharge. It's only watering. The common bacteria involved in the conjunctivitis and in keratitis are gram-positive cocci, gram-negative cocci, and Pseudomonas itself. And if it's a post-operative patient, sometimes you get atypical mycobacteria such as Mycobacterium cheiloni or fortuatum. Very rarely you get Mycobacterium leprae. The risk factors is many times we cause it by abuse of topical antibiotics. When we keep on giving for a simple viral conjunctivitis or any irritation in the eye, people use fourth generation antibiotic drops for 15 days to 1 month, and or they taper antibiotics. Antibiotics should never be tapered. It should be abruptly stopped in 5 days or 7 days. If you do this, if you over abuse the antibiotics, you can get fungal infections in the eye. So also topical steroids. When there is little itching in the eye, instead of giving anti-allergy medicine, they give steroids. That causes local immunosuppression, and that can give rise to, again, fungal infections in the eye. So immunocompromised patients, of course, and minor trauma which is neglected. And of course, you get infections following corneal or eye surgery like corneal grafts and other things. There are other various risk factors. So if the cornea is involved, besides the watering, you'll get pain, redness, discharge will be there. There'll be a lot of debris in the tear film. The lids will be edematous. You see the top patient unable to open his eye. There may be a hypopion, a fluid level in the anterior chamber that you can see here. And the cornea may have an abscess which is seen. And iridocyclitis, that is inflammation of the brown portion of the eye. You get what is called keratic precipitates, or the anterior chamber appears very turbid. See, this is the distance between the cornea and the brown portion. This is not clear. It is quite turbid. This is called aqueous flare. It will typically give you watering, but no discharge from the eye at that time. This is chronic iridocyclitis. Again, you can get watering, but no discharge, but you get synechia. So the eye pupil gets all distorted, stuck behind. If you dilate it, it gets stuck at places. And these are the keratic precipitates. These are white clumps of cells from the iris which are stuck to the back of the cornea. Here also, as you can see in these pictures, sometimes it's in a triangular pattern like you can see in this first picture. Please understand that no watering or discharge occurs in any retinal conditions like macular degenerations, retinal detachment, diabetic retinopathy, vitreous hemorrhage. So all these conditions at the back of the eye, as you can see, the picture here is of any optic nerve conditions like papilledema that you can see here where the disc is congested. This is a diabetic retinopathy. They will not give rise to any symptoms of watering or discharge. So don't mix the two. It's only from the part which is in the front of the eye, the anterior portion, and usually from the nasolacrimal duct issues that you will get watering or discharge. Thank you for your attention. So just to summarize briefly, we talked about earliest at birth, ophthalma neonatorum. Then in children, after 6 weeks of age, you can get congenital blocked nasolacrimal passages, which you can massage or otherwise treat with probing. If it is adults, if it is early, antibiotics. Otherwise, If the nasolacrimal passages are blocked, either you remove the sac called dacryocystectomy, or you make a new passage called DCR or dacryocystorhinostomy. We talked about three common causes of watering, which is allergy, in which you get stringy or ropey discharge, or infection. If it is viral, you'll get just watery discharge. If it is the bacterial, you might get some sticky discharge with some pus coming out, more so if the cornea is involved. And we talked about dry eye. 15% of them get watering, of course, with no discharge, and you need to treat them with artificial tears. Thank you so much, and I'll be happy to answer questions.
Thank you so much, sir, for this comprehensive talk. The presentation was so much informative. Sir, we have received few questions from our participating doctors. With all your permission, can I put them across?
Yes.
Okay. The first question is, what are the red flags that should prompt further investigation or referral in cases of persistent or severe eye watering and discharge?
So if again, if as I said, if all the causes that I mentioned to you are ruled out, then you need to refer the patient to the doctor, because he will then do a sac syringing and find out whether there is a blocked nasolacrimal passage, and then do either a DCT or a DCR surgery. Thank you.
Okay, moving to the next question, that is, what are the age-related changes in the lacrimal system and how do they contribute to the increased tearing and discharge in the elderly?
Uh, the lacrimal system is normally fully formed by ninth intrauterine month. So just before the baby is born, the passage is already patent. Sometimes the passage can be blocked by either epithelium or by mucus. So then it doesn't open. So that is a congenital nasolacrimal duct obstruction. But once that is cleared out either by massage or by a simple probing procedure, then it has no relation to watering in the adults. It remains patent entire life. Thank you.
Okay, the next question is, kindly explain the role of allergies in pediatric eye watering and discharge.
I did deal extensively with this during the talk, and I talked about there are different types of allergies. In India, it is usually perennial almost all the year round because of not pollen so much as dust and pollution that causes the allergy. You have to avoid giving steroids as much as possible and use dual action drugs. I mentioned some names like olopatadine or bipotestine or alcaftadine, which can be used, and avoid the use of steroids. Refer the patients when in doubt to eye surgeons who can then monitor them closely. Thank you.
Okay. Moving to the next question, that is, how does lacrimal duct obstruction present in infants and what are the recommended interventions?
I think I covered that both during the my talk as well as in the uh, question answer that followed. That if it's in a child, we do this Kriegler's massage. If it doesn't work, we will do a probing procedure. Thank you.
Okay, we are taking the last question for today's session, that is, kindly discuss the impact of digital device use on eye health in teenagers and its potential relation to eye watering and discharge.
Again, we covered this during the talk. I mentioned that 15% of patients of dry eye get watering as a symptom because the tears uh, evaporate from the eye. There are dry pockets, and there are some places where the tears are not spread evenly, so they may fall out of the eye, causing the watering. So we need to evaluate these patients. There is a whole battery of dry eye tests that we can do, and according to that, we prescribe artificial tears for these patients. Thank you.
Okay. Thank you so much, sir, for answering all the queries of our doctors. And I would also like to thank all the participating doctors for your continuous participation at our platform. Thank you once again, sir, for your valuable time and for being with us at our platform and sharing such valuable insights to us. Thank you so
Thank you.
much.
Thank you. Thank you.
With all your permission, sir, can we just stop our live now?
Yes. Thank
Okay,
you.
sir. Okay. Thank you, sir.
Thank you.